Picture this, a patient lying in a hospital bed, fully awake, fully aware, but completely trapped inside their own body. It's a terrifying reality, right? Their body is entirely failing them, either locking up into these agonizing, rigid spasms, or just going completely limp and flaccid. And through it all, their consciousness is 100% intact. Well, welcome to The Explainer. Today, we're diving into the harrowing world of two of the most potent neurotoxins known to medicine, tetanus and botulism. This is a critical side-by-side comparison, and honestly, it's an absolute must-know for your exams and your future clinical practice. So what actually separates a completely locked jaw from a completely floppy airway? It's a pretty profound question, isn't it? Both of these devastating conditions come from closely related bacteria in the Clostridium family, but clinically, they are total night and day opposites. And grasping this core dichotomy, the exact cellular mechanisms that push one patient into severe spasticity and another into profound flaccidity, is the absolute key to mastering these high-yield topics. No rote memorization required. Okay, let's look at our roadmap for today. We'll be covering the tale of the two toxins, the mechanisms of VAMP2 versus snare, spastic versus flaccid paralysis, autonomic overdrive and tetanus, some crucial treatment exam traps, and then we'll wrap it all up with a high-yield final review. Let's get into it. Starting right off with Section 1, Mechanisms, VAMP2 versus snare. Now, this is the war of the synapses. It is the absolute crux of our entire explainer. Let's look at the diametrically opposed targets of these toxins. Tetanus goes after the inhibitory interneurons. Specifically, it blocks the release of GABA and glycine. You can think of GABA and glycine as the literal brakes on your nervous system. So tetanus, it destroys the brakes. Botulism, on the flip side, cleaves snare proteins right at the excitatory terminals of the neuromuscular junction, which blocks acetylcholine release. So if tetanus destroys the brakes, botulism essentially destroys the gas pedal. Let's break down exactly how this happens with tetanus, step by step. So after tetanus spores get into a wound and germinate, the actual toxin, tetanospasmin, starts this retrograde axonal transport. Basically, it travels all the way up the nerve until it hits those presynaptic inhibitory interneuron terminals in the spinal cord. Once it's there, the toxin's light chain acts as a zinc-dependent endopeptide and snips apart a highly specific protein called VAMP2, which you might also know as synaptic rhabin. And without VAMP2, those inhibitory neurotransmitters are completely trapped. The result? Unregulated, totally out-of-control motor neuron firing. Moving on to Section 2, Spastic versus Flaccid Paralysis. Now, what's really fascinating is seeing how these tiny, microscopic mechanisms manifest physically in the patient. This is where we apply the rule of opposites. Because tetanus destroyed the neurological brakes, you get this unregulated, vastly increased motor activity. That leads to spastic or rigid paralysis. The muscles are just constantly, endlessly firing. But botulism, well, having destroyed the gas pedal by blocking acetylcholine, you get entirely blocked, decreased motor activity. The muscles literally can't fire at all, and that causes a flaccid paralysis. And get this, their directional flow is the exact opposite too. This is a really critical distinction to remember for your exams. Tetanus causes an ascending paralysis. Because of that retrograde transport in the spinal cord, it classically starts with the shorter cranial nerves, affecting the jaw and face first, and then it progresses, or ascends, down the neck, trunk, and limbs. Botulism, however, causes a descending paralysis. It starts with the cranial nerves, maybe causing drooping eyelids or double vision, and then it rapidly drops down the neck, arms, and legs. Okay, let's rapidly define the classic clinical triad of tetanus. First up is trismus, which most people know as lockjaw. This is the absolute first and honestly the most common symptom of a tetanus infection. So, pro tip, if you see a board question about a patient with a dirty wound who suddenly can't open their mouth, you are dealing with tetanus until proven otherwise. Next in the triad is rhesus sardonicus. As that spastic paralysis works its way through the facial muscles, it causes this sustained, really unnatural spasm. It physically pulls the facial muscles back into what looks like a disturbing, wide sardonic grin. But here's the thing, the patient isn't actually smiling. Their facial muscles are just forcibly locked in this state of extreme, high-tension contraction. And finally, we have opisthotonus. This one paints a really vivid, terrifying picture of the sheer physical force of that unregulated motor firing. You see, the extensor muscles of the spine are incredibly powerful, so when the toxin forces them into a continuous spasm, they completely overpower the flexors. This causes an exaggerated, rigid arching of the back. It can get so severe that literally only the patient's heels and the back of their head are touching the bed. It's intense. Which brings us to Section 3, autonomic overdrive in tetanus. So as a patient transitions into the second week of a severe tetanus infection, the clinical picture takes a really dangerous turn. We start seeing autonomic nervous system disturbance, or ANSD. The autonomic nervous system basically starts taking these wild swings. Patients will experience heavily fluctuating heart rates, literally swinging back and forth from extreme tachycardia to bradycardia. Blood pressure goes crazy too, bouncing from hypertension to hypotension. Add to that some profuse sweating, GI stasis, and heavy tracheal secretions. In severe cases, these wild cardiovascular events actually become the main cause of death late in the disease. Now, let's contrast that autonomic presentation with botulism. Like we just said, tetanus presents with this hyperactive, sweaty, tachycardic autonomic profile. But botulism's autonomic features exactly the opposite. It's an anticholinergic-like presentation. You're going to see dry mouth, constipation, dilated pupils, and a total lack of sweating, which is called anhidrosis. So remember it like this. Tetanus is wet and hyperactive, while botulism is dry and blocked. So the really crucial takeaway here is understanding the diverging ultimate causes of death. In tetanus, an early death is often due to respiratory failure from a laryngeal spasm. The airway literally chokes itself shut through rigid muscle contraction. Late death, as we mentioned, is from that autonomic cardiovascular instability. But in botulism, the cause of death is simply respiratory muscle paralysis. The diaphragm and the intercostal muscles just go completely flaccid and they stop working. Okay, moving into Section 4, crucial treatment exam traps. Pay very, very close attention here, guys, because making the wrong choice in real life can be fatal. Here's a massive warning. Penicillin should absolutely be avoided in tetanus. I know it might seem like a standard go-to antibiotic for gram-positive bugs, but penicillin actually binds to GABA receptors. And what did we learn a few minutes ago? Tetanus already blocks GABA release, so by giving penicillin, you are further antagonizing the GABA system, which can severely exacerbate the patient's spasms. In fact, it's been straight up associated with increased mortality. Just don't do it. So, what is the correct clinical protocol then? Well, first off, metronidazole is your antibiotic of choice. Second, you must give human tetanus immunoglobulin, or HTIG. And this brilliantly illustrates a key physiological concept. You absolutely must give the HTIG before you debride the wound. Why? Because debridement can accidentally release more toxin right into the bloodstream. HTIG only deactivates circulating toxin. It can't do anything to reverse the toxin that's already bound to neurons. So the sequence is: give the antitoxin to catch any newly released poison, then debride the wound, and finally manage those spasms with benzodiazepines like diazepam to force some inhibition back into the system. Oh, and just a quick crucial number for your flashcards, 0.1 IU per milliliter. That is the exact threshold for a protective serum antitoxin level. If your patient is at or above that number, they generally have adequate protection. Now here's a wild fact that catches so many people off guard. Surviving a natural tetanus infection does not actually confer immunity. Crazy, right? The tetanus toxin is just so extraordinarily lethal that the tiny amount required to cause severe disease is actually too small to be highly immunogenic. The body's immune system just doesn't mount a lasting defense against it. Because of that, survivors literally have to receive a full primary vaccination course even after they recover. All right, we made it to Section 5, the high-yield final review. We've covered a ton of ground today, so let's synthesize everything into your ultimate cheat sheet. Bringing it all together. Tetanus targets VAMP2 at inhibitory terminals, and that causes an ascending spastic paralysis with sweaty, hyperactive autonomic features. You treat it with metronidazole and HTIG. Botulism, on the other hand, targets snare proteins at the excitatory terminals, causing a descending, flaccid paralysis with dry, anticholinergic autonomic features. But definitely notice the row for consciousness here. In both of these absolutely terrifying conditions, despite having completely opposite paralysis mechanics, the patient's consciousness remains totally 100% intact. So, as we wrap up this explainer, I want to leave you with this thought. When test day comes, or when you are standing there in the emergency department, will you remember the microscopic mechanisms that actually drive the disease, or will you fall for the penicillin trap? Understanding the why behind the what is honestly your greatest tool as a clinician. Keep reviewing, keep connecting those clinical signs to their cellular actions, and you will absolutely ace this. Until next time, stay curious and keep learning.